Our last speaker for our symposium today is Dr. Isaac. He's an assistant professor of theology at Loma University with the School of Religion. He received his MA and PhD degrees from UCLA with an emphasis on immigrant identity, linguistic anthropology, and Near Eastern culture. In addition to excellent scholastic chops, Dr. Isaac also brings a decade's worth of experience in healthcare leadership and management in adult and elderly residential care facilities. This experience has formed him to be a staunch advocate for senior health and quality of life. Now, Dr. Isaac's research interests include health disparities and end-of-life care. He studies how care can be optimized for diverse populations, particularly at the end of life. Please join me in giving a warm welcome to Dr. Isaac.
Good morning. I don't know if everyone can hear me. Can you hear me? Good. So this is where the lecture starts going south. Just kidding. Just wanted to thank. Do I have my clicker here? Oh. Thank you. So I would like to extend my gratitude to the organizers of this conference, particularly Dr. Wee, for inviting me to share my insights on a fascinating yet unresolved concept within the medical community, which is the physician-patient relationship, or the acronym I use is PPR. This term in particular intrigues me because its definition and the notion of relationship remains elusive and often skewed towards autonomy and confidentiality rather than embodying a genuine connection. What does quote-unquote relationship truly entail? Historically, it denotes a connection or association marked by mutual behavior and emotional ties. However, does this definition align with the physician's approach towards patients during consultations? In 1972, Robert Veitch introduced 4 models of the doctor-patient dynamic. First, priestly, secondly, engineering, third, collegial, and lastly, contractual. The priestly model, rooted in the Hippocratic Oath, emphasizes treatment to aid the sick without harm, a dominant paradigm until the 1970s. The engineering model views the doctor as a consultant, with the patient having full authority over treatment decisions. The collegial model advocates for a more interactive and partnership-oriented approach, while the contractual model emphasizes a mutually agreed pact grounded in principles of autonomy, fidelity, veracity, and justice. That was 1972. 20 years later, Emmanuel expanded on these concepts and proposed a 4-pronged model of paternalistic, informative, interpretive, and deliberative, each offering a nuanced perspective on the physician's role from advisor to collaborator, emphasizing the importance of aligning with patient values and preferences. However, these models, while theoretically insightful, often fall short into practical application, failing to capture the complexity and individuality of clinical encounters. Physicians must tailor their approach, starting by inquiring about the patient's preferences for communication and decision-making. Irrespective of the model a physician adopts, the significance of language and discourse in shaping the dynamics of relationship cannot be overlooked. The linguistic elements that foster positive interactions often remain unconsidered in traditional models of the doctor-patient relationship. The substance of communication is equally crucial as the manner of its delivery, including the contextual cues that inspire positive emotional responses. Forming a quote-unquote relationship during clinical interactions presents challenges, particularly the feasibility of establishing a meaningful connection within the confines of a quote-unquote 15-minute consultation. Reflecting on my personal experience as a patient at UCLA Medical Center, brief consultations did not facilitate a substantial bond or connection. Furthermore, the relational aspect of medicine has become more intricate and eroded over time. Constraints such as time, the increasing number of patients, extended wait times, the transactional nature of contemporary medical encounters have contributed to this complexity. A century ago, the doctor-patient relationship was inherently personal, characterized by doctors making house calls within their community. Contrastingly, today's healthcare system is a vast network involving various stakeholders, including administrators, pharmaceutical companies, insurers, and government regulators, complicating the traditional doctor-patient dynamic. This evolving landscape has led to a growing mistrust towards physicians, exemplified by incidents like the viral YouTube video 3 years ago of a physician in the Loma area refusing to care for an elderly Spanish-speaking patient using her daughter as a translator. With the abundance of technology and the options to have translators, this incident was unnecessary. Critical thinking and the effective transfer of knowledge and information are essential for patient health, raising questions about the best methods for information exchange. What is the conduit through discourse that allows easy transference? How do you get it? You ask questions, conduct examinations, etc. All the answers may be there if you let the person talk and you listen, but what if the person doesn't speak your language? Then how do you attain it? What about the cultural differences, where sharing personal problems is not normative? The importance of speech cannot be underestimated. In the context of discourse, word usage will also impact outcomes. Using top secret, esoteric medical knowledge forms that only trained physicians know will not help the encounter. Effective communication, especially considered language barriers and cultural differences, is paramount. The strategic use of discourse facilitates the free dissemination of information, highlighting the impact of language choice on outcomes. Moreover, there is a discrepancy in perceptions, with patients not necessarily feeling that a relationship has been established. This predominantly physician-centric perspective calls for a reevaluation to better align with patients' expectations and physician capabilities. Hence, the principal argument is to contest the conventional characterization of the physician-patient interactions as a relationship. We can agree that both parties want a strong relationship and definitely need it, but fail to achieve it oftentimes. Therefore, my presentation introduces the physician-patient impact model, advocating for a paradigm shift to redefine the dynamics of physician-patient interactions, acknowledging the limitations of clinical encounters within certain timeframes, while striving for meaningful engagement. I have 3 objectives in this research that is ongoing. First is to analyze the micro-level nuances of language in clinical encounters. That is to systematically dissect and analyze the micro elements of language use in clinical settings, particularly focusing on how emotive language influences patient-centered interactions. Secondly, to develop a positive impact communication model, to create an actionable strategy that equips the clinicians with effective communication techniques. This strategy aims to enhance their persuasive abilities, enabling them to establish positive patient perceptions and outcomes within the limited time frame of a typical healthcare visit. And thirdly, to promote enhanced patient-centered or patient experiences in consultations. That is to foster a more profound understanding of the impact of emotive and affirmative language on patient experiences. This objective seeks to redefine the dynamics of clinical encounters, moving towards a model where brief interactions can yield significant positive impact on patient well-being and perception. So the methodology for this research that I'm doing and conducting is to emphasize the power of emotive language and its impact in clinical encounters within the constraints of these time-limited interactions, because this addresses a significant gap in existing literature and practice. My analysis seeks to derive from observations of consultations and conducting interviews and analyzing web-based transcripts. The theoretical framework will integrate elements of linguistic anthropology, which was part of my training, psychology, and medical sociology. The goal is to deconstruct and analyze linguistic elements, including the selection of clinical encounters with cancer patients. Research on medical consultations have revealed that the use of specific emotion words and communication between patient and physician can significantly affect the patient's experience, fostering a sense of affirmation, positivity, solidarity, and mutuality. Some key insights based on research findings include, first, establishing a rapport, there's abundant literature on that. That's the initial step of establishing rapport in medical consultations, which is active listening, open body language, and the use of affirmative statements. This creates like a welcoming atmosphere and a supportive environment for patients. Secondly, expressing empathy, where the doctor expressions of empathy through both verbal acknowledgement of the patient's feelings and nonverbal cues such as nodding and maintaining eye contact, plays a crucial role in building trust and solidarity. Third, positive reappraisal. We're encouraging patients to view their concerns from a different, more positive perspective, helps in mitigating anxiety and fostering a sense of hope and mutual support. Some of the verbal and nonverbal communication that's effective. Again, affirmative words, nods, smiles, etc. And then responding to emotional cues, where your emotional literacy is there, where you're acknowledging and responding appropriately to emotional cues and concerns that can significantly impact the therapeutic alliance and patient satisfaction. And then lastly, mutuality and communication. We're encouraging a dialogue involves shared decision-making, acknowledging that the patient's experiences and symptoms do matter in giving voice to them. This includes using, instead of the first person singular, the first person plural, like we, to signify teamwork and joint effort in addressing health concerns. So these studies have shown that by integrating these communication strategies, medical doctors can significantly enhance the patient consultation experience, promoting a therapeutic environment characterized by empathy, positivity, and mutual respect. In the verbal or linguistic approach, the relationship between language and emotion have been discussed from phonetic, semantic, and discourse pragmatic perspectives, and even inclusive of cognitive perspectives. But these studies have been disconnected to other realms of data science. So motivated by this need for a more multidisciplinary collaboration, I propose an integrated platform for patient emotion recognition and decision support. This proposed solution can serve as a collaborative framework towards clinical decision-making and support. The patient-physician impact model proposes at its core and contends that although the brevity of consultations may not allow for traditional developments of trust in a quote-unquote relationship, physicians can still strive to leave a substantial positive impact on these patients and their families. This approach shifts the focus from the duration of interaction to the quality and depth of the connection made within these constraints. My primary objective in designing this new model is to pinpoint and understand the key micro-level components of doctor-patient discourses that cumulatively create such a positive impact upon patient well-being across cultures in the limited time of a typical encounter. The emotive impact discourses of positivity and mutuality is a subcategory that I am going to explore in this research, where I advocate for the term for positivity and mutuality, highlighting their collective role in shaping patient attitudes. While a physician's ability to improve medical conditions of a patient may vary, the potential of emotive language to increase patient perceived satisfaction persuade patients who are non-compliant, and foster a significant impact can be achieved. A quotation from Hippocrates particularly resonates. Quote, "There is an art to medicine as well as science, and that warmth, sympathy, and understanding may surpass the surgeon's knife or the chemist's drug." The envisaged impact can be actualized through a range of emotive utterances that evoke a sense of affirmation, positivity, solidarity, and mutuality, transcending cultural barriers. By deconstructing the micro-level elements of language use, we can develop a practical strategy to equip clinicians with enhanced persuasive skills and the ability to elicit positive patient perceptions during healthcare visits. Some of the findings and potential challenges. So in doing this literature review, just briefly, just kind of highlights some of the findings in the existing literature on this subject. So Pawlowski's study in 2012 in an article titled "Verbal and Nonverbal Behavior of Doctors and Patients in Primary Care Consultations, How This Relates to Patient Enablement," analyzed 88 recorded primary care consultations. They found that consultations perceived as patient-centered, or where the patient verbally dominated, were more likely to enable or encourage patients. Socio-emotional exchanges, such as agreements, approvals, laughter, and legitimation, correlated with patient empowerment and support. A more recent study in 2023 by Adibi et al., in an article titled "Emotion Recognition Support System," where physicians and psychiatrists meet linguists and data engineers, emphasizes the significance of recognizing patients' emotional states by caregivers. It highlights a common scenario where patients refrain from expressing emotions when discussing somatic symptoms and complaints. Clinicians often lack the expertise or time to identify patients' verbal and nonverbal emotional cues, leading to an emotional recognition gap between clinicians and patients. The study advocates for an interdisciplinary approach combining psychology, linguistics, and data science to improve emotional recognition and verbal communication. However, it is critical to acknowledge the complexities and complex realities of verbal interactions in medical contexts. For instance, studies such as Kuiper's in 1989 in this linguistic anthropological approach to the patient interaction demonstrates the contrast between medical interviews and everyday conversations, showing a tendency for physicians to control the dialogue and often interrupt patients and resist patient-initiated questions. Moreover, other studies show that doctors interrupt patients far more often than the reverse, especially if the patient is of the same gender and ethnicity as the doctor. These interactions, typically occurring within the bureaucratic settings or official centers of power in hospitals and clinics, underscore the importance of adopting a more egalitarian interview style to enhance the impact of medical consultations. Lastly, in a study by Mark Takanen in 2023, text-based doctor discourse online and patients' experiences of empathy, explored how empathetic responses in medical consultations, both face-to-face and online, significantly affect patients' experiences. By examining text-based consultations at an online clinic, they identified communication types that influence perceptions of empathy. They found that empathetic experiences were positively associated with doctors' use of psychosocial talk and procedural statements. Empathy was conveyed through expressions of support, interest, encouragement, and deep emotional support, including reassurance, advice, even doctors' self-disclosure of personal experiences similar to the patient's. The study highlights the importance of rapport-building strategies, such as acknowledging patients' experiences and emotions, expressing optimism, and wishing for a speedy recovery as crucial elements of empathetic and effective medical discourse. Some of the potential challenges is that physicians constantly report challenges in establishing robust relationship with patients, despite concerted efforts to be informative and accessible. And we know that every encounter is not going to reach its ideal, but we can, achieve a positive impact. Even after thorough discussions with patients and their families, a significant disconnect remains, with physicians feeling unable to build meaningful connections. So my argument is, could the adoption of a positive emotive language model, possibly an extension of beneficence, offer a solution? And I think that is the case. Some of the practical implications, recently in a study by Falkenstein, in an article titled "Characteristics and Correlates of Word Use in Physician-Patient Communication," delved into the linguistic nuances of healthcare interactions. Their findings indicate a preference among patients for physicians who limit the use of negative emotion words. Conversely, patient adherence decreases when physicians frequently use first-person singular pronouns. Emotive words that convey positivity, happiness, and inspiration may bridge communication gaps. And we find that too in the biblical model of Jesus using positive words and inspirational words in healing those who are sick in the Gospels. In conclusion, the intersection of medical practice and linguistic anthropology presents a unique opportunity for enhancing doctor-patient interactions. It is imperative for both parties to perceive success in their communication, ensuring that relationship is mutually beneficial and not unidirectional. Employing the term relationship carries the potential for positive connotations, inspiring both physicians and patients to strive towards establishing meaningful connections. However, I propose that the term impact as a more apt descriptor to emphasize the goal of these interactions, highlighting the importance of positive outcomes over the conventional terminology of a relationship. Thank you.
Thank you, Dr. Isaac. I know we've chatted about this briefly before, but just wondering whether you can expound. Again, we're talking about the difference between a patient-physician impact and a patient-physician relationship. I'll be honest that in a lot of our teaching, we talk about the patient-physician relationship, but what I hear you saying is that it's really difficult to establish that relationship within the time constraints and the communication difficulties that you've aptly documented. Would that be sort of fair to say? All right, so here's my two questions, actually. The first question has to do with AI. There was a recent article that was published in, here we go. Their study published in JAMA Internal Medicine indicates that artificial intelligence assistant-generated responses to patients' questions are better than physicians' responses regarding quality and empathy. So if we are using empathy, and it feels like if we're talking about AI, it feels better to talk about impact than relationship. But if we're talking about people, it feels sort of reductive to talk about impact versus relationship. I'm looking at the time. Maybe let's get to this question and we have time. I've got another one, but.
So this is a good question. The aspect of relationship implies this human connection. One of the reasons why I want to detour from that is because I think in human relationships, the importance of making an impact, being intentional about making an impact, is more conducive towards outcomes that can be achievable within 15 minutes, as opposed to establishing a quote-unquote relationship. Because oftentimes patients, while we may use the term relationships and desire to achieve relationships, that's not the reality. And so I'm reducing the the motive, the potential realities to impact. What impact can you make? And I think this term may be able to drive physicians to think more in different lines, as opposed to what has been, espoused in these last 30 years as a relationship. And so we'll see.
When does an impact slide into a relationship then?
I don't know if we're ever achieve a relationship. Doctor comes in, he knows your name. We may, share a story together, give a hug or embrace, and then we spent 15 minutes. Do we establish a relationship? I don't know if the patient feels that way. The doctor comes in, gets trained with being able to read emotional cues, gets trained in being able to use certain verbal resources to elicit a more comfortable environment, and then is intentional about making an impact, and certain words that are affirming, positive. The patient feels that. At least the doctor can leave the encounter by saying, I made a positive impact. And even though I cannot change the health condition or outcome, but I made an impact, and I can be satisfied with making an impact, as opposed to the nebulous notion of, did I have a relationship or not? I guess the relationship barometer is not objectively, there's not this objective standard where we can say, this is definitively what it looks like when you establish a relationship. And is that satisfactory to both the patient and the physician? Whereas a positive impact, I think, is more, traceable. We can define it a little bit clearer. So that would be my response.
And in terms of, last question, and unless there's others, but in terms of professional formation, I think it's easier to, I don't know, because it's not been my experience, but it's easier to think about, in my experience, it's easier to think about forming my identity around a relationship with my patients rather than forming my identity around making an impact. Yeah, I'm just wondering about the differences between the two.
So I'll use Jesus as an illustration. When he encountered the woman with the issue of blood, did he make an impact or did he form a relationship? Most likely he made an impact. And so you find it many times in biblical models of healing where the relationship factor is not a part of the interaction, but the impact is. And so I think it's helpful to be able to derive from that. Maybe we need to rethink the paradigm and more towards making an impact than actually forging a bond or a relationship.
Thank you. Thank you for attending. This closes our session. Please let's give Dr. Isaac and all of our presenters a round of applause.